All right. Well, here we are at chapter 56, clinical decision making, and many people often refer to this as critical thinking. It's the ability for you to take all the information that you've gathered during your patient contact and in a very short period of time come up with some differentials and determine what's wrong with your patient, make a diagnosis. And I know I said the D word, and many people believe that we don't diagnose, and I'm not sure that that's accurate today. With all the diagnostic tools that we have and the information that we have, we certainly are very capable of diagnosing things like STEMI and NSTEMIs. Certainly if your femur is angulated at a 45-degree angle, we pretty much can diagnose that that's fractured. So we do make diagnosis, and in part it's based on our ability to make decisions based on the information that we've acquired. So, as usual, I'm having a little trouble getting it to advance to the next slide. Here we go. The learning objectives for this particular chapter are that we compare the medical care in the pre-hospital environment with medical care in other settings. Distinguish critical, life-threatening, potentially life-threatening, and non-life-threatening patient presentations and your decision-making process for each of those. We'll evaluate the benefits and shortcomings of protocols, standing orders, and patient care algorithms, and the biggest one being that not everybody's going to fit into a protocol. Certainly not everybody's going to fit into an algorithm. We're going to define the parts, the stages, and the sequences of the critical thinking process that you use. We'll describe the effects of the fight or flight response and the positive and negative effects it has on your ability to make decisions. And if you remember, the fight or flight is the sympathetic nervous system and evolves around the release of hormones like epinephrine, norepinephrine, and dopamine. And we'll talk in a little detail about that later in this talk. We're going to summarize the 6 R's of putting it all together. Reading the patient, reading the scene, reacting and reevaluating, and revise the management plan, as well as review the performance afterwards. The cornerstone of effective paramedic practice is your ability to make good decisions on the care that you provide to your patient. And that requires us to gather information, whether it be, your initial assessment, looking for serious life threats, your secondary survey, including your sample and your OPQRST, talking with the patient, what you see, hear, smell, putting all that stuff together in a really short period of time, and then developing some sort of plan to care for the patient based on what you think is wrong with them. And of course, the cornerstone of effective paramedic practice is that you provide the best patient care that you can, or quality patient care. What's often being done now in pre-hospital medicine is that you ask folks, do you provide quality basic care or quality patient care? And the answer is yes. And the response to that answer might be, well, prove it. What sort of metrics are you looking at that would indicate how well your performance is when it comes to taking care of sick patients or injured patients? To be effective as a paramedic, you've got to gather good information. And with good information, you're going to make good decisions. But with bad information, if your patient assessment is weak, if you're not gathering all the information, if you're not following a systematic approach, to gathering all the information each and every time you do your patient assessment, then you may come up with some bad or missing information that certainly could lead to bad outcomes with your patient. We work in a really unique environment in the pre-hospital arena. We have to assess and care for patients in a really short period of time. When you look at what a physician has in perhaps an emergency department prior to the patient being admitted to the hospital or transferred to another facility, they may have hours to do all kinds of diagnostics and to do some sort of, do some sort of a patient assessment that's far more thorough than what we can do. We have that same responsibility to do a good patient assessment as do doctors and nurses and mid-levels like your nurse practitioners and PAs. But we don't have the full complement of a lab person, a radiology person, nurses, a doctor, a radiologist. We don't have that. We have limited personnel. We deal with extreme weather conditions. We deal with very difficult situations, whether it's family members that are belligerent or crowds that are belligerent. We see people often in the worst situations in their life, and the emotions are high. We have to deal also with the different types of people that we may have around us on scene. We treat both emergent and non-emergent care, or not emergent and non-emergent issues. And we have to be able to determine which is which. And in order to do that, we've got to gather the right information. We have to determine what sort of care plan we're going to use to take care of this patient. And care plan, protocol, whatever you want to call it, it's just that. We have to decide within our scope, what can we provide this patient at this point in time based on our assessment that will lead to good outcomes. And that requires us to apply clinical judgment. And clinical judgment isn't really something that you can teach. We'll talk about it, but it really isn't something that you can teach. Clinical judgment is something that occurs as a result of, things like pattern recognition, as a result of things like just multiple years of experience in caring for patients. We work independently for the most part. Yes, we've got a set of protocols that guide and direct us. Yes, we have a scope of practice that determines what we can and cannot do. But when we're out there seeing patients, we're making decisions independently on what is in the best interest for this patient at this time. And as we gather the information, it's important that we develop a differential diagnosis. And a differential diagnosis is a potential diagnosis that would cause the patient's chief complaint. So if a person is complaining of chest pain, for example, differential diagnosis certainly could be heart attack or acute myocardial infarction, but it also could be a pneumothorax. It also could be pericarditis. It also could be costochondritis. They're a pleural rub. There's all kinds of things that will cause chest discomfort. So we have to be able to, through pattern recognition, through our own experiences and intuition, develop a diagnosis. We do work within a scope. And within that scope, the scope of practice identifies the types of treatment that we can provide. Certainly as an example, starting an IV is within the scope of practice of a paramedic. Intubating is within the scope of practice of a paramedic. And we work under the auspice of our medical director. In other words, we're functioning under our medical director's license. And our medical director sends us out with a set of protocols or standing orders or algorithms that we follow and we try to plug our patients into, but we understand too that not everybody's going to fit into a protocol. You may have that COPD patient who, because of their pneumonia and their hypoxia, now is having a heart attack. So what protocol do you plug that person into? Do you plug them into the exacerbation of COPD? Do you plug them into MI? Do you plug them into pneumonia? And that requires us to be able to, to think on our own to make those types of decisions. The nice things about protocol, standing orders, and algorithms, and you'll be familiar with algorithms, if you haven't already taken courses like ACLS and PALS, PHTLS and AMLS, they do have some patient care algorithms that list in linear order things that should be done when a patient presents with a particular condition. We'll get comfortable with those as we get into those courses. But the other thing that's important about the nature of our care is that it is standardized. That we develop a systematic approach to assess our patient each and every time and stick with that so that we don't get tunnel vision, so that we don't miss really important things that may affect the type of care that we provide our patient. Limitations to protocols and standing orders and algorithms I've already mentioned is certainly that not everybody's going to fit into a protocol or a standing order or an algorithm. And it requires us to use good clinical judgment or critical thinking in order to determine that. Our bradycardia algorithm says that if you've got a patient whose heart rate is slow and they're symptomatic, that you give them 0.5 milligrams of atropine IV. But if I knew that this patient had skipped dialysis and had a bedside testing for potassium and determined that their potassium was extremely elevated, that might be the cause of their bradycardia, and atropine's not going to work in that situation. And that requires us to understand what high potassiums do to the body. That requires us to understand how the drug atropine works, rather than just rote memorization of an algorithm. So those are things that we'll certainly focus on as we go through the course. I like to think about the way that we do assessments and the way that we come up with a diagnosis is this inverted pyramid of reasoning. Your pager goes off, the person's complaining of chest discomfort. We want you to start throwing up every differential diagnosis that you can think of related to chest pain. Think really broad. It's going to help you avoid tunnel vision. And focus on those differentials that pose an immediate threat to life. I'm not going to focus initially on costochondritis as a cause of chest pain. I may get there depending on my assessment, but initially I'm going to look for those differentials that pose immediate threats to life, like a thoracic or abdominal aneurysm, a massive myocardial infarction. Those are the things I'm going to focus on finding. And then through our assessment, our focus history and physical exam, through our sampler history, we can narrow the process by eliminating differentials that we know aren't causing the problem. And eventually we'll end up with one or maybe two or three potential diagnoses as to what could be causing this chief complaint in this patient. So critical thinking involves explaining, analyzing, making decisions, solving problems, and investigating. In short, critical thinking is thinking about something from many different perspectives, many different angles, not just one. And I like to think of critical thinking as the problem-solving skills that answer the why. When we first learn things, we often learn them because that's the way they are on the paper. That's what this protocol says. The protocol for chest discomfort says if they have this, we give this, 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 and this. But I think it's so important that we understand why we do this, why we do that. And that, again, is something that you learn as you become more experienced as a paramedic. So the critical thinking process requires you to have an adequate fund of knowledge. We are lifelong learners. I think I mentioned that in one of the very first chapters, that we continue to learn each and every day. I learned something new just the other day concerning lead AVR on a 12-lead ECG. I'd always been taught that that was the orphan lead, that It doesn't look at anything, but if there are elevated ST segments in AVR, that is significant for left main disease. The left coronary artery is occluded, and I didn't know that. And so you learn stuff every day. So you have to have an adequate fund of knowledge. You have to be able to focus on specifics and multiple data. And focus is the key here. Our biases will get in the way of our ability to focus. The environment will get in the way of our ability to focus. The patient's ability to react with us, the family members and friends, how they react with us, all have an effect. Excuse me. All have an effect on our ability to focus. We have to be able to gather and organize data. We have to be able to deal with the medical ambiguity that is out there. When you ask your patients certain questions, particularly concerning their history, and they start unloading all sort of things about their childhood or surgeries that they had that really don't have anything to do with their ankle pain, we have to be able to sort through that, respecting the individual and what they're trying to tell us because they believe they're being helpful, but also understand that that really doesn't have anything to do with what's going on right now. And that leads to that bullet point about us being able to distinguish between what is relevant information for what's happening right now and what is irrelevant. We have to be able to analyze and compare similar and contradictory situations. We have to provide rational decision-making, reasoning, and we have to construct logical arguments for the treatment that we deliver. Because once you plug that person into a particular protocol, and once you go down that path of treatment, you at some point, either through your narrative or through run review or audits of your runs, have to be able to justify why you did what you did. Because a person reading what you've written or reading the report may not have the same conclusion that you do. Concept formation is part of the critical thinking process as well, and concept formation is the ability to understand the overall concept of what care is needed for this patient at this time. It begins with when you receive the page, and you know what you're going for, and we all understand too that just because I'm paged out for a stroke doesn't mean when I get there the patient's having a stroke. But certainly once you get that information on the page, or somebody from the scene radios you some information, you start to think and you start to form concepts of the type of care that might be needed in this particular situation. Upon arrival, you're evaluating the mechanism of injury, the nature of illness. You're doing your initial assessment, looking for immediate threats to life. You're getting a good sampler history, as well as doing a physical exam, doing diagnostics that we have the ability to do. And then you're taking all that information and you're comparing all that with the knowledge base that you have. What do you know about the anatomy and physiology of this particular body part? What do you know about the pathophysiology of this particular disease? What previous experiences have you had with patients with COPD or heart attack or cancer? And then pattern recognition, which is something that we'll talk about here in a bit as well, is important in your ability to integrate the data, is being able to recognize patterns. And you really have to consider your attitude and bias and how it impacts your ability to interpret data. Now, with pattern recognition, you need to be alert for patterns. Compare the information of what is in your knowledge base about various diseases, and it's the ability to recognize patterns that increases as you gain more experience. When you look at a patient and you see Kussmaul's breathing, and you know that Kussmaul's is associated with diabetic ketoacidosis, or you look at a patient who's pale and sweaty and they tell you it came on suddenly and their pulse is bounding and rapid, you know that that's what low blood sugar looks like. Or if somebody has crushing substernal chest pain that radiates their neck and jaw and down their left arm, that's heart-related chest discomfort. And you're able to identify that because you can see the patterns of the disease processes that the patient is presenting. Now there's a little pattern exercise here to the bottom right-hand corner of the slide, and the exercise is trying to figure out how many triangles you see in this particular drawing. So I'll give you a second or so to look at that and maybe count up how many triangles you see in this particular drawing. And so as not to keep you in suspense any longer, there are no triangles in this drawing. A triangle is 3 lines that intersect each other. And there are no 3 lines that intersect each other in this particular diagram. What our mind does, what our biases do, is fill in those blanks. You might believe you see 1, 2, 3, 4, 5, 6, 7, 8 triangles here, when in fact there aren't any. And that is in part because of our biases and what we believe we see. Some factors that influence your ability to make good decisions, we're back to that personal attitude and your biases. If it's 3 o'clock in the morning and you get rustled out of bed for, a drunk who's in the ditch, that may not sit well with you, or for a frequent flyer who's fallen and can't get up again, and you arrive on scene, that just may not sit well with you, and as a result, it may affect, and you don't think it would, but it may affect the way that you provide care. If your patient is uncooperative, if your family members are uncooperative and being difficult, that's going to affect your ability to make good decisions. How compliant your patient is, not only with their existing medications or in the treatment of their existing disease, but also how compliant are they in answering your questions? How compliant are they in allowing you to provide your treatment? If they have distracting injuries, distracting injuries work 2 ways. One way that a distracting injury works is that if a distracting injury causes so much pain in the person, they may not realize that they hurt somewhere else. And so when we talk about immobilization, one of the criterion for immobilizing is if they've got a distracting injury, they probably need immobilized, because if they have an injury that's so painful, they may not recognize they have neck or back pain. And distracting injuries can affect us. If we arrive on scene and somebody's got a gunshot wound to the face and we see all that soft tissue damage, we may be focusing on that soft tissue damage when in fact we need to be focusing on the airway. So distracting injuries can affect our ability to make good decisions. Environmental considerations. Certainly we work in some really hostile environments. Environments that are extremely hot, environments that are extremely cold, environments that are dangerous are going to affect our ability to make decisions. And then how many people we have to do the job that we need to do. If we're working with limited staff, that certainly may affect our decision-making process. One other thing about critical thinking is the application of principles versus preference. Now, when you think about it, splinting is an example. The principle of splinting is that we immobilize the joint above and below the potential break. How we do that is preference. And medicine, particularly pre-hospital medicine, courses like AMLS and courses like PHTLS focus on principles rather than preference, because we understand that, even in different counties, from one county to another, the preference of how you immobilize a fracture may vary. And if they all immobilize the joint above and below, what difference does it make what what variety or brand you use. The other thing that is important in the critical thinking process is that when we've applied treatment or we've done something, did it work as intended? And what is the patient's condition after we treat them? Now, we hope that certainly they improve, but if they don't, if they continue to trend down or they continue to get worse, we may need to revise our treatment plan. We may need to think of something else that we need to do in that situation. When the call's all over, I've always said that we are our worst critics, and that nobody, tears a call apart more than we do. When you've finished a call and you don't have a good feeling about it, particularly if there's a bad outcome for the patient, you're really thinking about, did I do everything I was trained to do? Did I recognize everything I should have recognized? What could I do to be better? So it's a personal reflection that occurs after the call, and it's or could even be a formal critique as part of a run audit. But those sort of things help evolve and develop your ability to critically think. So building your critical thinking skills requires you from restraining from your emotions. If you emotionally get wrapped up in this call, your biases and your feelings are going to prevent you perhaps from seeing what you need to do. Look at things from different perspectives. Don't do things because, that's the way we've always done it. Look at things from different perspectives. I'm not an advocate of being a cowboy or cowgirl paramedic. I'm not an advocate of stepping outside of scope. I'm not an advocate of stepping outside protocols. But I am an advocate of looking at things from different perspectives. Just because we're going to teach you certain ways to do things and that sort of stuff doesn't mean that's the only way that things can be done. Analyze the information that you gather, ask lots and lots of questions, solve problems as they arrive, and distinguish fact from opinion. That's an important part of critical thinking as well. Medicine, to include emergency medicine, is on a fast track to evidence-based practice, where we begin doing things based on the available evidence that shows it works. And if there's evidence out there that doesn't show it works, the question should be, why are we doing it? Why do we do that? Particularly if there's evidence out there that shows it may be harmful. If we're doing it because we've always done it that way, that's not the way to do business. Learn from others. Learn from others. We are, lifelong learners. We're continuous learners. Ask lots of questions. Get involved. That sort of stuff. Remain up to date. Go to conferences. Read journals. Read studies. Question things as they happen. Here's an example of critical thinking. Suppose you need to measure exactly 1 cup of water and all you have in your kitchen are 2 containers. You know that the smaller container holds 3 cups and that the larger container holds 5 cups. How can you use these 2 containers to measure exactly 1 cup of water? Well, the answer is you fill the 3 cup and pour it into the 5 cup. You fill the 3 cup again and you pour it until the 5 cup is full, which leaves you 1 cup in the 3 cup container. That's an example of critical thinking. When we think about when we have to apply assessment-based patient management, when we have to apply assessment-based critical thinking, when we have to apply assessment-based clinical reasoning, all the same thing. In context, most critical patients don't require a lot of critical thinking. If I've got a patient, particularly trauma patients, if I've got a trauma patient who's got a GCS of 3, that doesn't require a lot of thought. C-collar, longboard, ABCs. They require immediate and practiced treatment. Moderate to minor acuity patients, they need the greatest amount of critical thinking. Their symptoms are less dramatic, they're more subtle, they're harder to pick out. The complaints may be vague, particularly when it comes to medical problems. And the other thing is that you must be able to think under pressure. And whenever you're placed under pressure, or whenever you're stressed, your body's going to release hormones from the sympathetic nervous system, the fight or flight response. And one of the chemicals that you release is dopamine. And dopamine in the right amount is an extremely important hormone because it helps you problem solve. It helps you critically think. But when you couple too much dopamine with excessive amounts of epinephrine and norepinephrine and cortisol and aldosterone, this really impairs your ability to make good decisions. So you've got to be able to think under pressure. In order to prepare yourself mentally to do this, one of the things that you can do is practice, practice, practice. Practice skills until they're near intuitive. Logical, repeatable, and reliable assessment techniques, head to toe, ABCs, primary, secondary, all those things that we've been taught. They're logical, they're repeatable, they're reliable, and if you do them each and every time that you see a patient, you're going to be okay. Use a mental checklist. Stop and think. Identify your scene in the situation. Make decisions and understand that, the decisions that you make are going to have consequences. And if you do your logical, repeatable, reliable assessment techniques, you're able to make much better decisions. Maintain clear and concise control of the scene and evaluate your actions and evaluate the patient repeatedly. Did I do the right thing for this particular patient? How are they responding? Stay calm and don't panic. That's the easiest way to lose control of a scene. That's the easiest way to fall apart, is to stay calm and do not panic. One of the things that I always used to do when going to a major grinder or going to a report of a CPR in progress is to check my own pulse. If my own pulse is flying along about 120 a minute, I need to calm down. I need to just relax. I need to take some deep breaths, and I need to know that everything's going to be okay. Assume and plan for the worst case scenario when you get there, so that if you're in it, it's not a big surprise. And balance your assessments with your decision-making style as well. How you choose to make decisions often drives the type of assessment that you do. Here are some different decision-making styles. There's the situational analysis, and that is reflective, thinking before you act. It could be impulsive, and that's acting before you think. When you think about situational analysis, I'm in a particular situation. I can reflect back on the last time I was in a situation like this and what I did and what worked well and what didn't, and then make a decision. Or situational analysis is, I'm here with a patient that I think is having a heart attack. I just treat him for heart attack. And then if it turns out that it was pneumonia or something else, I'll have to deal with that later. Data processing, there's two types of styles with data processors. There's the divergent style, and they will gather multiple sources of data before making a decision. And then there's the convergent style, and that's the person who operates with just one source of data. I think most of us are learning to be divergent with all the diagnostic tools that are out there and all the sources of data where we can acquire information about the patient's condition, that's kind of the style that most of us take. Decision making can be anticipatory, and that's where you anticipate problems and head them off before they ever, before they ever start to snowball. Or you can be reactive. You can be a reactive decision maker and wait till the patient presents with clear symptoms before making decisions on how to care for them. You may think, well, I think this person's in shock, but I'm not sure, so I'm going to wait. I don't know why people would follow that path unless they were just unsure about themselves or the patient condition and need more clear symptoms to make that decision. Reactive is one of the decision-making styles. So putting it all together, there's 6 R's: read the scene, read the patient, react, reevaluate, revise your management plan, and review your performance. We know how to read the scene. It begins with your initial assessment, your mechanism of injury, nature of illness, one patient, do I need C-spine immobilization? Do I need additional resources? Your general impression is reading the patient, reacting to what it is that you see, what it is that you acquire as far as information, and then reevaluate your plan, reevaluate what you've done and revise your management plan based on the patient's progression, and then later, after the call, or certainly as part of chart audits, reviewing the performance. So here's just a visual of the clinical decision making, the 6 R's: read the patient, read the scene, read the patient, react, reevaluate, revise your management plan, review performance, and start all over again with the next patient contact. So in summary, clinical decision making is the cornerstone of effective paramedic practice. We work in some really difficult environments, and we have to be able to respond in those particular situations. Your clinical decision-making process is generally governed by protocols, standing orders, and patient care algorithms, but we also know that patients don't always fit into a protocol. They don't always fit into a standing order or a patient care algorithm. So it requires us to critically think. And critical thinking involves some fundamental elements of being able to analyze that sort of stuff. Clinical thinking mandates that you read the scene and read the patient. You react to what you read. You reevaluate the scene. You reevaluate the patient. You revise your treatment plan as needed, and then later review your performance to ensure quality patient care. So that ends the chapter for us. Should you have any questions, feel free to get a hold of me by email. I think you also have my cell phone number as well. And with that, we're done, and I'll talk to you soon.